you see and share me, hear me?
Yes, we can hear you, sir.
Okay.
You can see.
Okay. So I can proceed. So I am Dr. Mukherjee. I am an associate professor in pediatric neurosurgery working in National Institute of Neurosciences and Hospital, Dhaka, Bangladesh. So my topic is management of multiloculated hydrocephalus. As because this is a mixed type of audience, at first I want to describe what is hydrocephalus at first. See, in this screen, there are 3 CT scan images, all are axial images. In the left side, you see the black part of the center of the brain, that is called ventricle. Very small ventricle, and outer dense white matter is bones, and in between bones and ventricle, that is parenchyma. That is a normal CT scan. But the middle part, the middle CT scan, see the water is accumulated, that is called hydrocephalus. But the last one, that is actually emerging. See the accumulated water is divided into many compartments by septum. Compartment is called loculus. So this is called multiloculated hydrocephalus. Or somebody may call, as because there is multiple septum, so somebody called it is multiseptated hydrocephalus. The management of simple hydrocephalus, that is the middle one, is straightforward. We can do CSF diversion either by endoscopic third ventriculostomy or by different type of shunt. But the management of multiloculated or multiseptated hydrocephalus is not straightforward. It is a complex disease and the treatment is very complex. So that's why I want to discuss on this issue. See, the multiloculated hydrocephalus is happened due to either infection or due to hemorrhage. So there are some common cause of multiloculus. The ideal treatment of multiloculated hydrocephalus is making pathway between the loculus. So make all loculus to a single one. So then we may do endoscopic third ventriculostomy or CSF diversion. The problem is there are so many protein deposits. So excess protein causes fenestrated septation is blocked. So the fenestration will not stay in future. How we overcome that situation? That means reduce the protein content, or there may be degraded portion from hemorrhage that may also cause the same problem, that is blockage of the fenestration do by endoscope. So how we overcome it? We actually do intraoperative irrigation. That is the main message from today's talk. How we give intraoperative irrigation? We make some fluid that is called Ringer's lactate and add some sodium carbs there, and it makes warm. So then we use flexible endoscope. We have flexible endoscope, even the latest one, that is chip-on-tip flexible endoscope we have. So we give endoscopic irrigation under direct vision and remove the debris of different types by endoscopic irrigation. So make fenestration and give irrigation at the same time. If we get the floor of the third ventricle is normal, anatomy is normal, we can do third ventriculostomy at the same sitting, or we can abandon third ventriculostomy if the anatomy is strongly distorted. So after then we may do another VP shunt or other shunt procedure later. So this topic is already published in a renowned article. So this is the flow chart which will follow the irrigation purpose and management purpose of multiloculated hydrocephalus, which is the content of flowchart. Observe CSF color during the fenestration. If it is clear, we observe third ventricular floor. If it is accessible, we do ETV and forward plexus coagulation as an adjunct if the patient is below 1 year. And we must observe prepontine cistern by flexible endoscope. If there is too much scarring in the prepontine cistern, additional BP shunt done in the same sitting. But if there is not too much scarring, ETB and CPC is enough. If the third ventricular floor is inaccessible, so we do BP shunt at the same sitting. But if the CSF is turbid or if the CSF content is not visible, so we give only irrigation and aspiration, and if necessary, we do external ventricular drainage or ventricular subgaleal shunt. Then final procedure, that means CSF diversion, do later. So we do a study in our center for comparison in between irrigation and non-irrigation in case of separation of multiloculated hydrocephalus. See, the irrigated group, their outcome is good. If you permit, I can show a small video. So, is it possible to show a small video?
Please proceed, sir.
This video is visible to you?
There is a depression found in the ependyma due to jet.
This video is visible to audience?
No, sir, we can't see, sir.
You can't
Flow
see?
of water that is important to determine any cyst underlying thick wall. So
But it shows it is sharing to all.
there is a depression found in the ependyma due to jet flow of water.
Are you observe this video?
We can only hear the audio, sir. We are not seeing the video, but you can proceed, sir.
That is important to determine any cyst underlying thick wall. So the cyst is detected as it is a convex dome-shaped structure just below a muscular artery. See the cyst extended from 12 o'clock to 3 o'clock, and the vessel, large vessel crosses over the cyst. So I try to point out from which point I can penetrate the cyst by Bugby wire. So see, there is a dome where my tip of the Bugby is directed, and just I touch and give some pressure and give some cautery in coagulation mode. We use usually 8 to 10 power and penetrate it, and see there is a foggy material comes out through the stomach, and there is a lot of foggy material that is glittering and looks like debris. And now I use shielding the technique to entry within the cyst. Now we are within the cyst, and after entering the cyst, we give irrigation and aspiration for removal of the old debris that was maybe a consequence of infection. Sometimes this is a consequence of hemorrhage. And now we are in the closed cavity where there is a lot of debris. See, debris comes out from the wall of the cyst, and when we give more irrigation, comes more debris. Now we comes out outside of the cyst in the main ventricular cavity and see a lot of debris is found within the ventricular cavity. See, a lot of debris is found within the ventricular cavity, which we remove by irrigation and aspiration. And extracystic spillage can prevent by quick Scheldinger technique.
Thank you. Can you hear me?
Yes, sir, we can hear you, sir. Please proceed.
So here I finish my presentation. Thanks audience for hearing my presentation, and thanks organizer to organize such a nice program. That is a very good hybrid program, technically very high quality, and hope in future organizer also organize this type of program that is helpful for neuroscience. Here I give some YouTube links where people can see the usefulness of different type of treatment of hydrocephalus. That's why people may learn, general people may learn that what is the disease procedure, what is the management procedure, what is the desired complication. So people will more cooperate for the treatment system. So thank you very much. Thanks all.
Thank you, Dr. Sudipta, for your presentation. We hope that the participants have learned one or two things from your research. Well, thank you so much.